Good evening, friends. Today we are here to for another episode of 42.0 show, where we have a detailed discussion dialogues for Indian diabetic patients. I am your host, Dr. Sachin Mittal, endocrinologist based in Chandigarh, and I welcome you all for today's academic session of 42.0 show. The topic which we're going to talk about today is diabetic foot, the complications associated with diabetes. One of the major complications associated with diabetes is diabetic foot, and it can present in various forms, in the form of diabetes cellulitis, in the form of diabetic foot ulcer, and sometimes it can complicate to a diabetic foot gangrene also. In such situations, the outcomes may not be great, and eventually many people undergo a foot amputation as well. Unfortunately, diabetes is one of the leading causes of a non-traumatic amputation. In this day and age where medical sciences have so evolved, so much advances have taken place, still, many people lose their feet or lose their toes or lose their some portion of the feet as a result of diabetes related complications, and this is something which is very deplorable. This is something which to a great extent is preventable. We want to help our patients take care of their foot up in a better manner, right? And that is something so important. If we incorporate foot care in our day-to-day diabetes practice, it leads to long-term outcome benefits for so many of the patients. So I still remember that, when we are taught to counsel a patient with diabetes, to educate a patient of diabetes, one of the components of that is diabetes self-management education is foot care. And in a common vernacular language, I often say to that patient कि जितना आप अपना चेहरा देखते हो उससे ज्यादा आप अपना पैर जरूर देखो दिन में एक बार. So we all have a habit of looking in the mirror at our face. Similarly, we should tell our diabetic patients to inspect their foot on a regular basis, on an everyday basis. Why is it important? Because if somebody is doing that, he or she will come to know okay, when there is a swelling developing, when there is a ulcer developing, when there is a little bit of a wound happening, when there is a pain happening, when there is a inflammation happening, when there is a redness happening, then he or she will take prompt care at that point of time, and the outcomes are remarkably different. It's like a day and night difference if somebody with diabetic foot gets diagnosed and treated appropriately and early versus somebody who ignores this. And this is very important because many patients with diabetes have diabetic neuropathy, which leads to a situation where the foot ulcer may be beginning to develop, but the person may not be aware about it. As a result of which, what happens is many times the patients continue to walk on that feet, and as a result of which, what happens is that ulcer keeps on becoming bigger, and takes a very unfortunate turn. Many times it gets infected. These things are especially prevalent in our country because there are still traditions where, because of religious and some other reasons, walk bare feet also, and that can lead to diabetic foot ulcers also. For talking on this important topic, we have a very eminent speaker with us, Dr. Sayan Ghosh. Dr. Sayan Ghosh is a senior consultant endocrinologist. He has done his medical education from the renowned medical colleges in the country, and is currently based in Calcutta. His NTM endocrinology has been from Kolkata only, and currently he is a senior consultant endocrinologist at Kothari Medical Center as well as ILS Institute, Kolkata. Thank you so much, Dr. Ghosh, for sparing your time and coming on this show. And our audience is looking forward to your clinical acumen and your insights, how we can, help our patients, how they can help, how our audience can help their patients with diabetes foot lead to better outcomes.
Myself, Dr. Shan Ghosh, consultant endocrinologist at Kothari Medical Center, Kolkata. Today, we going to discuss regarding the very important complications of diabetes, the diabetic foot complications. We know that diabetes is a global worldwide problem nowadays, and India is the second largest capital of diabetes, having so many people living with diabetes. Majority is uncontrolled, and more than 50% is even undiagnosed and or in the pre-diabetes stage. So it is very much important time for to discuss regarding the to increase the awareness regarding diabetes and its complications, how diabetes can affect the different organs. That is also very much important. We know the diabetes affect the vasculature, the vessels, the microvasculature and macrovasculatures, and these microvascular damages and macrovascular damages are very much common. Within the microvascular damages, there are the several options that is a kidney injury, diabetic kidney disease, eye, the retinal problem, diabetic retinopathy, and also the nerve damages, that is diabetic neuropathy. Number two, in the macrovascular damages, it can causes the myocardial infarction, causing heart attack, cerebral attack or stroke, and also the peripheral vessels are also getting involved and causing peripheral arterial disease, causing pregangrene and gangrene like situations. So combined way, the microvascular damages of like the neuropathy in the foot or the leg and the macrovascular damages in the peripheral arterial diseases both can lead to the diabetic foot related complications. Why the foot is very important in diabetic patients? Because we know the neuropathic problem starts from the foot. It is a length dependent. The longest nerve affect first from the distal end. So the foot, the toes, then gradually goes upwards. The neuropathic problem starts. First, the positive symptoms like tingling, paresthesia, altered sensations, burning sensations, pain, and after that there is numbness or totally loss of sensation, etc. So due to the unawareness of the pain or less pain sensation, those type of the foot are very much prone to develop injury and causing a major ulcer without any pain. Another macrovascular damages, that is a peripheral arterial disease causing impaired supply of the blood to the limb or the foot. So in combination or any of the one can lead to the diabetic foot related problem. And in addition to that, the foot deformity is accelerate this problem. The foot deformity also causing the more and more pressure to a particular point at a foot, along with neuropathy or reduced blood supply due to the peripheral arterial disease can causing the diabetic foot ulcer or the other foot related problem. Now going to discuss the prevalence. I am already discussed diabetes is the second largest capital. India is the second largest capital in diabetes. The prevalence is 9.6% among the adult aged 20 and above. The number of people with diabetes in India is the second highest in the world. In India, is 1 in 100, 1 in 11 adult is living with diabetes, and 53%, I have already told, the more than 50% of the patients with diabetes are still undiagnosed. They even not know that they are having diabetes because they are not doing any screening test. There is no symptoms, so they are waiting for the symptoms, not doing any screening testing, ultimately causing the complications started from very beginning. Now the foot complications I have already discussed. There is a neuropathic symptoms, peripheral vascular disease causing foot ulcer. Now ulcer development. What is ulcer? Ulcer is a breach in the skin continuity. That is the ulcer. So why the ulcer develop? Because the diabetic patients having some nerve problem. They cannot sense the pain. So when the foot at a particular pressure point there is repeated friction at that particular site, there is micro injury or micro damage. Patient cannot sense, so patient cannot give any protective measure or patient cannot afford a protective measure. So after that there is a formation of ulcer at the particular pressure point. So that is the foot ulcer, and this ulcer can aggravate if there is no pain sensation and patient is very much unaware. They cannot check their food daily regularly, and very much improper food hygienes, and also if the inadequate blood circulation to the foot ultimately causing rapid development or rapid increasing size of the ulcer along with some pregangrenous changes. Now due to the ulcer development, there is some raw area in the ulcer. In diabetic patient, if the glucose level is very much uncontrolled, those particular patients are having a very much high risk for sepsis. There is much more increased chance of infection into the ulcer, causing some purulent discharge, or there is some non-healing ulcer. If the ulcer is infective, it is non-healing, it will not heal properly. So there is a poor wound healing. And ultimately, if the patient is still unaware about their glycemic status, their proper food hygiene, not doing proper dressing, not acquiring proper protective measure for their foot, ultimately excuse me, ultimately they will lost their foot. The limb will can be amputated to protect her or his life. So the extensive ulcer formation along with pre-gangrene or gangrenous changes can lead to the limb amputation also. So foot ulcer account for 7 to 11% of all hospital admission in diabetic patients. And even a diabetic patient can die due to his or her foot only. That is very much depressing situations. Even the cardiac cause of death or the renal cause of death is the most common cause of death in diabetes. Still now, the death due to the diabetic foot ulcers are very much rising day by day because of only a proper lack of proper awareness regarding the diabetic foot care. And up to 1/3 of the diabetic patient may suffer from the diabetic foot ulcer. This is not a small number. This is very big number of the patient is having some diabetic foot related problem. Now, this is the prevalence. I have already told that 11 to 14% of the diabetic patient will develop foot ulcers, and 6 to 23% of the foot ulcers may worsen and eventually lead to amputations. And diabetic foot ulcer is being more common in men than women in type 2 diabetes patient than type 1 diabetes patient. And it is very much important that a patient with past history of diabetic foot ulcer in same foot or in the opposite foot, they are having more prone to develop another foot ulcer in future. The value reaches 40% within 1 year and 65% within 3 years. So much common in a history of past history of diabetic foot ulcer. Now, how to classify, how to grade the severity of the diabetes foot ulcer? A patient can come with a very small ulcer at the repeated friction site due to the improper footwear, due to the repeated injury in the foot, or there may be deformity in the foot that can lead to the ulcer development due to clawing of the toes. We know the claw toes. So the tip of the toes will more prone to getting injured repeatedly because a higher the all the pressure in the body are distributed through this tip of the toes. So ultimately there is a formation of corn or callus at the pressure point. We know that when the pressure when there is a more pressure exertion in the sole, there is a formation of corn or the callus formation. And this callus is growing, increasing in size, forming a large corn. And surrounding the corn, there is a high chance for development of the ulcer formation at the side of the corn. And other than that, if there is some fissures or cracks in the foot, it is very much common in all patients, in all individuals also, even in the non-diabetic individuals also. But in diabetic individuals, this micro crack or fissures ultimately can give the entry of the infections into the foot, and that may be devastating because for the formation of the larger foot ulcer. On the basis of the natural history, the clinical conditions, stage 1 it may be normal, stage 2 is high risk for ulcer formation but not having any ulcer. What are the patients for high risk for ulcer? Number 1, patient is having neuropathy or nerve damages in the foot. Number 2, patient is having some foot deformity. Number 3, patient is having some peripheral vascular disease. Patient is having intermittent claudication, rest pain in the foot, impalpable or very poorly palpable the peripheral arterial pulses, etc. And the ankle brachial index is getting decreased day by day. So those are the high risks for the high risk patient for the foot ulcer formation. Stage 3 is the ulcerated foot ulcer. Already ulcer formation begins. Stage 4, there is surrounding erythema because the ulcer, when there is an entry of infections or entry of microorganism and ulcer is getting infected, there will be surrounding erythema. The surrounding area will be swollen, that will be redness in the surrounding area, that is called erythema, and ultimately the surrounding foot will be very much swollen, tender, and that is called cellulitic foot. That is stage 4 is a cellulitic foot. Now, due to the tissue edema, there will be compromised local vascular supply even with a normal, even there is no peripheral arterial disease. Due to the local tissue edema, the compromised microcirculation can lead to some necrosis in the area, or if in addition patient is having peripheral arterial disease, the necrotic area will be much more predominant and patient may land up into the pre-gangrenous stage and ultimately can lead to gangrene also. That is the stage 5, when the necrosis started to begin due to the local tissue edema or tissue hypoperfusion, or there is existing peripheral arterial diseases. Now stage 6 is the already patient is getting amputated or patient is a candidate for amputation. So this is stage 6. So this is based on the natural history from milder to the severe category. Now based on the severity, the Wegener classification, grade 0 is intact skin, there is impending ulcer, patient is having high risk for ulceration, but at present there is no ulcer, skin, there is no breach in the continuity of the skin. Number 1 is a very superficial ulcer, just the breach in the continuity of the skin. Ulcer doesn't extend only to the subcutaneous tissue but not going to the depth more than that. Grade 2 is a deep ulcer to the tendon, bone, or ligament, but not involving the bone. That is without osteomyelitis. That is grade 2 ulcer. Grade 3 ulcer is the osteomyelitis. Already bone is getting involved. Ulcer is so much deep that it ultimately extends to the bone and bone is getting involved. That is called osteomyelitis. And stage 4 ulcer is the gangrene. Already the blood supply is getting compromised. Blood supply in the toes, forefoot, etc. Formation of the gangrene in the toes, the distal part of the toes or the forefoot. Stage that is grade 4, and grade 5 is the gangrene of the entire foot. Now, how the diabetic foot ulcer forms, that is, I'm already told there are 3 major factors. Number 1, deformity, obviously. Number 2 is a diabetic peripheral neuropathy. Number 3 is the peripheral arterial disease. On the top of that, if the blood sugar level is controlled, the patient is having normal blood glucose level, the risk of the ulcer formation will be very much less. But if the blood sugar level is very much high, that is high, so the prolonged hyperglycemia ultimately causing collagen cross-linking disorder, cell defense will be impaired, there will be more chances of the inflammation, decreased inflammatory response, and disrupted neoangiogenesis, so improper healing. So ultimately lead to defective wound healing. Now, diabetic peripheral neuropathy, we know that there are 3: sensory nerve, motor nerve, and autonomic nerve. Sensory, motor, and autonomic neuropathy. Sensory is loss of protective sensation, motor is the bone deformity, autonomic is a dry skin, no sweating, skin fissures, etc. So, person's skin will be dry, there will be no sweating, so very much dry, thin, atrophic skin, there is no sweating, skin fissures very much common in this autonomic neuropathic foot, etc. Motor, there is some motor weakness also. This motor weakness ultimately leads to thinning of the muscle. We know that in between the phalanges, in between the metatarsal bone, there are some small muscles in the foot. If this muscle is getting atrophied or thin out, then the bone will become more prominent and ultimately causing deformity, or the more pressure point will be there in case of the atrophic foot, muscle atrophied foot. So due to the motor weakness, the bone deformity aggravates. So, and sensory, there is loss of protective sensation, that is called LOPS, loss of protective sensation. Now, what type of the sensation? There is a decreased pressure sensation, decreased temperature sensation, decreased vibration sensation, and decreased touch sensation. So we can test with the use of the monofilament, that is for the pressure. We can use the tuning fork testing for the vibration sensation. We can do a simple fine touch or crude touch with this the cotton for only the touch sensation, etc. So that will be impaired. And we also can do the VPT, that is the vibration perception testing. Particular threshold for the VPT will getting higher if the vibration sensation is getting impaired, right? So all these 3 factors ultimately can cause foot ulcers. Next slide. So the diabetic foot risk classification on the priority basis and indication and type line and suggested follow. So the active pathology based, that is the urgent, high, moderate, low, very low. What is the urgent? That is active, the pathology based, open wound or ulcerative area with or without sign of infection. So already the ulcer is very much wide, but there may or may not be any signs of infection. New neuropathic pain or pain at the wrist, sign of any active Charcot deformity. There may be red hot sole and midfoot or the ankle. There may be vascular compromise, sudden absence of the peripheral pulses. And so those are the urgent, that is active pathology. Immediate referral is required as determined by the specialist. Now, for the high risk, that is ADA risk category 3, the diabetic foot in remission, presence of diabetes with a previous history of ulcer or lower extremity amputation, chronic insufficiency is there, so there is skin color changes or temperature differences. Immediate or next available outpatient referral, every 1 to 2 monthly follow-up is necessary because there is no ulcer, but there is a high risk for development of the foot ulcer after one ulcer remission. Now, moderate risk, that is ADA risk category 2, there may be peripheral arterial disease plus minus loss of protective sensation, peripheral pulses is getting diminished, and presence of swelling or edema is already there. So the referral is within 1 to 3 weeks, that is, if not already received regular care, every 2 to 3 months follow-up is very much necessary. Now, low, the ADA risk category 1, there is only loss of protective sensation but no peripheral arterial diseases signs or no diminution of any peripheral pulses. So loss of protective sensation is long-standing, non-changing deformity. Patient requires prescriptive and accommodative footwear. Referral within 1 month, every 4 monthly follow-up is necessary. And very low risk, that is ADA risk category 0. There will be no loss of protective sensation, no signs of peripheral arterial disease. Patient seek education on the topic just to aware the patient there may be a chances of the foot ulcer in diabetes. So referral within 1 to 3 months and at least annual foot checkup is mandatory. So those are the category. Category 0, there will be no neuropathic symptoms, there is no peripheral arterial disease. Category 1, there is only neuropathic symptom, no peripheral arterial disease. Category 2, there is neuropathic symptoms plus minus peripheral arterial disease, and also diminished pulses are also there. High risk category, there is a past history of diabetic foot ulceration along with this chronic venous insufficiency and other neuropathic symptoms. And urgent is the already having an active wound or ulcer with or without infections. So therapeutic strategy for the diabetes management is very much mandatory. The early initiation of the combination therapy because you have to reduce the blood glucose level very fast. So obviously, if there is any active infections, always preferred option is insulin therapy initiation. So initiation of the insulin is mandatory for any active infection. Present if the diabetic foot ulcer patient is having very high blood glucose level. So if there is no any active the infection is there, we can control with the oral medication also, but we should start with the dual therapy or combination therapy. Novel medications are there that we all know, that DPP4 inhibitor, SGLT2 inhibitor, and GLP-1 receptor agonist. We can start metformin with any one of them, or we can start without metformin with these combinations between these groups. So SGLT2 inhibitor and DPP4 inhibitor combinations. So these combinations are very much beneficial because these encounter the multiple pathophysiology behind the type 2 diabetes, and SGLT2 inhibitor ultimately causing blood glucose loss through the urine, increases beta cell sensitivity, increases glucagon. DPP4 inhibitor causing incretin effect, increase insulin secretion and reduces glucagon. Both can reduce the blood glucose level, and SGLT2 inhibitor is in addition causing some additional effect of lowering the blood pressure, lowering the body weight, and the DPP4 inhibitor is already weight neutral. There are very minimal side effect or adverse effect with the DPP4 inhibitor. So if we can combine SGLT2 inhibitor and DPP4 inhibitor, that will be safer, rapid and sustained glycemic control. Not only that, from the cardiac aspect and from the renal aspect also, there are several cardiac beneficial effect has been proved with the several SGLT2 inhibitor, and also the SGLT2 inhibitor proved to have some Renal protective effect reduces proteinuria, so that would be better from the organ aspect also. Not only the metabolic benefit, not only the glycemic benefit, but also some additional organ protection is there with this combination of SL2 inhibitor and DP4 inhibitor fixed dose combination. Next slide. So SL2 inhibitor and DP4 inhibitor in diabetes management, dapagliflozin in combination with the sitagliptin was well tolerated and led to a clinically meaningful reduction in the glycemic parameter and body weights that were sustained through 8 weeks of treatment. So no regaining of the body weight in a long run. So HbA1c reduction is also very much persistent and body weight reduction is also very much persistent. So benefit of the DPE4 inhibitor, additional benefit in cases of the diabetic foot ulcers. So how the DPE4 inhibitor can affect the wound healing. There are some beautiful articles, wound healing effects of DPE4 inhibitor and emerging concept of managing diabetic foot ulcer. Now DPE4 inhibitor shows a promise in local wound healing of diabetic foot ulcer in addition to its already established glycemic control. So many of such cases, the patient is started on the insulin therapy, then we can add the DPE4 inhibitor in addition to the insulin. Number one, to reduce the insulin dose requirement. Number two is just to accelerate the wound healing. Not till now is not recommended, but several studies has been proved is a beneficial effect on the wound healing. So DPE4 inhibitor improved wound healing of diabetic foot in 3-month randomized trials also. The diabetic patients are very much prone to develop foot-related complications. We know that the diabetic other organ damages like kidney damage, eye damage, heart problem, cerebral problem. So the foot problem is also very much important because it is a combo of multiple factors. Number one is a neuropathic problem. Number two is a peripheral arterial disease. Number three is a deformity. On the top of that, uncontrolled diabetes. So all can lead to the diabetic foot ulcers. Or if the patient is having a high risk for foot ulcer, we can do a regular, very frequent follow-up to check for the foot, counsel the patient for proper foot care. Don't walk in barefoot. For every diabetic patient, it is very much important to know that don't walk in barefoot. Always wear a proper footwear in how indoor or in the outdoor settings, and also check the foot daily. Dry the foot after getting wet and check you in between the fingers if there is any cracks or not. Cut your nails properly horizontally. That is very much important. Give some moisturizer to prevent some cracking or fissuring. So at-risk foot are very much frequently should be very much frequently monitored, and if already a minor ulcer developed, we should prevent from getting it infected because proper glycemic control is the cornerstone. If the wound is getting infected, we give the proper antibacterial therapy along with proper offloading is mandatory, and also proper glycemic control and proper wound dressing. But if the wound is getting infected but not getting proper care, ultimately it can lead to some necrosis, or in addition to the peripheral arterial disease, the limb or the wound can getting having some gangrenous changes in future, and that can lead to the limb amputation. So that is the worst outcome of a diabetes patient, that the limb can getting amputated due to the limb diabetic foot ulcers, etc.
Yeah, thank you so much, Dr. Ghosh. So, what are the potential ramifications of diabetic neuropathy on foot health? Because we know that one of the factors, apart from vasculopathy and infection, which leads to development of diabetic foot ulcer, is diabetic neuropathy. Because many patients with diabetes go on develop neuropathy, especially small fiber neuropathy, sensory neuropathy, as a result of which what happens is that sometimes they develop an abnormal foot dynamics because of abnormal foot position, as a result of which sometimes what happens is they continue to have they develop foot problems, and sometimes even the foot ulcer starts developing, they are not even aware about it. So so how can we early identify such things and manage and mitigate these complications?
So at the earliest, we should properly screen for the complication in each and every diabetic patient. The diabetic patient is having neuropathy or not. Even before the onset of symptoms of neuropathy that I have already told, that is a tingling sensation, burning sensation, paresthesia, etc. We can do a bedside screening with the monofilament, with the cotton, with a tuning fork that the nerve function is intact or not. We can do a bedside VPT also to check for the vibration perception testing. And if there is any abnormality, we can go for a nerve conduction study testing to detect the neuropathy earlier. Now we have to check the patient is having LOPS or not, that is loss of protective sensation or not. And we also check bedside, that is patient is having peripheral pulsation proper. The limb pulses are proper or not. If it is getting reduced, we can do a handheld Doppler testing, or we can go for a USG color Doppler testing for that to detect the patient is having any peripheral arterial disease in addition or not. So if the patient is having a loss of protective sensation or plus minus peripheral arterial disease, then we should be more aware of that. If the patient is not having anything, that is no LOPS, no peripheral arterial disease, then every yearly, we should check for a diabetic foot. Related there, if there is any new appearance of neuropathic symptom, new appearance of peripheral arterial disease, etc. Number two, if there is any one is there, either LOPS is there or peripheral arterial disease is there, we should be more cautious, and we should frequently monitor every 2 to 3 monthly. We should check for the limb. We should go for the testing, and we should tell the patient for proper foot care. Check your foot daily. Even with a mirror, that is, there are some mirror is available. With this mirror, we can check the sole of the foot in between the fingers. We can check by our bare eyes that if there is any problem in between fingers, there are some fungal infections is there or not at the web spaces. If there is any cracks and fissures in the soles or not, there is any corn or callus formation in the foot or not, there is any prominent deformity of the foot or not, if anything is there, if the nails are very much malhandled or not properly cut down, is not. So if anything is there, we should be more cautious about it. If there is corn formation, we should remove the corn. If there is any fungal infection in between the web spaces, that we should give the proper treatment for that. If there is any fissures or cracks, we should give the proper treatment for that. If there is a deformity, we should give the protective footwear. So for all the patients who doesn't have ulcer but higher chances for developing ulcer, we should give customized preventive diabetic footwear with a soft insole and with the microcellular rubber and a hard outsole that is properly fit, not too tight, not too loose. That is very much important. Companies are manufacturing this type of the footwear after properly testing the foot pressure in Harris foot mat or other electronic machines. They are properly measured the foot pressure points. According to that, they are making the insoles or the whole shoes. So the preventive footwear is the utmost thing to to give the protection against the diabetic foot related ulcers or in future foot related problem.
At this point of time, I'm reminded of this thing that prevention is 100 times better than cure. So if we can have some preventive strategies which can stave off the diabetic foot complications, and that is something, there is nothing like it. And obviously, when there is a sepsis, when there is an infection, there are roles of antibiotics as well. So which preventive strategies they yield the best outcomes in staving off diabetic foot infections, and which antibiotic regimens are generally prescribed for the treatment?
Okay, if the already ulcer has been formed, then we should give the proper rest to your foot. Many of such patient comes to our clinic with a bare foot, even with ulcers. They're continuously discharging, but these continuously getting in touch in the floor, in the shoes. They're continuously is rubbing in the footwear. So much properly mentioned, improperly mentioned, and poorly handled. Those are, and very much prone to develop multiple infections, even after a single microorganism infection, getting antibiotic, but they are continuously getting infected because of they are not following the offloading strategy. They're not following the proper dressing and debridement protocol. So if the ulcer is getting formed, we should, number one is dressing and debridement is mandatory. We should remove the necrotic and the dead tissue. We should see the proper granulation, healthy granulation tissue at the floor, and with a normal saline dressing is mandatory. If there is any infections is there, proper antibiotic therapy. Empirically, most commonly we use in case of the this type of the diabetic foot ulcer infection, because it is usually polymicrobial, the combination of anaerobes, gram positive and gram negative organism. So most commonly we use the coamoxiclav, linezolid or clindamycin like antibiotic to give the full coverage. We can also give the IV piperacillins or this linezolid or clindamycin coverage for the patient empirically, but we should get a culture before starting antibiotic. We should get a culture or wound swab from the wound swab or any secretion from the wound after proper dressing, or we should take one tissue beads from the base of the wound ulcer and send it for culture sensitivity. Not only aerobic but both aerobic and anaerobic culture to be done. And if there is any culture, any organism is comes according to the sensitivity report, we should change the antibiotic after starting the initial empirical therapy. So number one is the dressing and debridement proper. Number two is the proper antibiotic therapy, empirical antibiotic followed by according to the sensitivity report. Number three is the offloading is mandatory. Patient should ask for the proper bed rest, complete bed rest. If it is not possible, then we should go for a total contact cast. That is casting or plastering of the limb so that we can prevent the contact of the ulcer with the floor or any other footwear. And number two, we can use the therapeutic footwear also, that the insole has been formed with a gap in the wound area so that that is getting not getting in touch with the floor on the other side of the footwear, etc. So proper customized footwear or total contact cast or complete bed rest, those are the modes of offloading. So offloading is mandatory. If there is a continuing pressure on the ulcer area also, then it will not be healed. That will be non-healing ulcer, ultimately to the non-healing ulcer. So, and number four is the proper glycemic control, the blood glucose control. So proper dressing debridement, antibiotic therapy, offloading, and blood glucose control. So these four is mandatory for the diabetic foot ulcer healing properly.
Yeah, thank you so much, Dr. Ghosh. Our listeners and viewers will be benefited with your detailed answer. At this point of time, we should talk a little bit more about about the preventive aspect, since we're talking about preventive strategies. So, one of the very important aspects when you talk of preventing any illness in diabetes is patient education. So I feel that we cannot underestimate the importance of patient education. And can you just highlight the significance of patient education in diabetes foot care, and what all aspects does it encompass, and just shedding a light on specific aspects like foot hygiene, footwear selection, self-examination practices, and many more.
Yes, it's very much important. It's the first and foremost thing that should be reinforced. That is patient education regarding the diabetic footwear, because majority of the patient is not aware of these diabetic footwear complications. So it is very much important. So nowadays there is a proper regular screening or the food testing is just many of the patients are completely not aware of that. So first thing is the first to tell the patients or regarding the multiple complications that what can happen in diabetes. Also it is possible to show some picture of the patient of foot ulcer, gangrene, etc. to the patient to be much more aware or much more that what can happen with if the diabetes is not getting properly controlled or not getting properly screened for foot. So those are the very important, that telling the patient that what are the possibilities, saying the giving some pictures to them so that the patient can see the what are the outcome that can happen in a diabetic patient if it is not properly controlled or not getting proper care. So and we go for a proper screening testing for the diabetic foot related problem like neuropathic testing or the vasculopathy, that is peripheral arterial disease testing. Every annually we should do the testing for each and every patient. And if there is any patient for any high risk for foot ulcer, we should prescribe for this preventive footwear that is very much essential to prevent the future foot infections. So obviously the health education is the first and foremost thing. Otherwise, anything we cannot do to a patient. We will prescribe, but the patient will not follow our advice.
So, thank you so much, Dr. Sayan Ghosh, for sparing your time and to be with us, to be with our listeners on this 42.0 show, where we have a detailed discussion and dialogues for Indian diabetic patients. And, it was very, very helpful because diabetes foot at the end of the day is a very, very important complication, an unfortunate complication which leads to a lot of morbidity in a lot of patients with diabetes. So, I'm sure our listeners will be more learned with your keen insights and your experience which you shared on this show. So thank you so much. And at this stage, I would thank all our listeners for joining in for today's academic session, and see you on another episode of 42.0.